Hello everyone. I'm Dr. Madhava Reddy, consultant at Hospitals, Hitech City. Welcome to the Tuesday masterclass webinar from Yashoda Hospitals, along with in association with Yashoda Hospitals Critical Care Department, along with IDCCM chapter Hyderabad. So we bring forth new and interesting topics along with the exam case discussion topics to the students and the exam going students and other interesting clinicians. To continue our learning experiences and also prepare ourselves for the practical exams. They have been very popular, and we keep these live sessions along with recorded sessions also made available to the students. And I have been getting a very good feedback regarding how they are very helpful in their practical approach in especially in practicals and at the same time at the bedside. And it provides a great opportunity to interact with very experienced physicians from all over India. And this has been a great academic work going on with Yashoda Hospitals. So here now I would like to introduce two good examiners, very experienced people. Dr. Amit Goyal, a consultant neurocritical care and neuroanesthesia from Medanta, the Medicity, Delhi, Gurugram. And Dr. Shubham Khandelwal, Associate Professor, Neurocritical Care and Anesthesia from Mahatma Gandhi Medical College, Jaipur. Welcome to you both, sir. And two students are going to present the case, Dr. Aqeel Pathan and Dr. Vathsalya, both are IDCCM exam-going students from Hitec City branch of Care Hospital. Welcome, both of you. And
thank you, sir. Thank you for having us.
You can go ahead with start presentation.
Okay, sir. Is it visible?
Yes, it's visible.
Visible.
Okay. Sure. So we have a 66-year-old male who was brought to the ER at around 11 o'clock in the morning on 5th of December with complaints of right upper limb and lower limb weakness associated with tingling and numbness, which began 2 hours prior at around 9 o'clock in the morning. He actually woke up from sleep at 8 o'clock and was apparently normal. Then subsequently, he had sudden onset giddiness followed by speech difficulty, which was associated with weakness on the right side of the body. And subsequently, he was unable to walk. And he had facial weakness, which was persisting. He did not have any history of seizures, any associated headache or vomitings, or any prior history of fever as such. And past history-wise, he is a known case of diabetes mellitus, and he's currently on metformin 500 mg BD dosing. He does not have any history of cerebrovascular accidents or any coronary artery disease prior, but he has a family history of coronary artery disease. His father expired of a heart attack. And personal history-wise, he's a businessman by profession. He's non-alcoholic, non-smoker, and no history of any illicit drug use, and consumes a mixed diet. And when he presented CNS examination wise, he was GCS wise, he was E3, V5, M6. He was drowsy, arousable, and following commands. He was protecting his airway, and his pupils were equally reacting to light 2 mm. But he also had right dense hemiplegia with the power on the right side of both right upper limb and lower limb. The power was 0/5. And along with that, he also had slurring of speech, which was associated with transcortical motor aphasia and right facial palsy with deviation of mouth to the left. And deep tendon reflexes were mute on the right side, and there was no blurring of vision or nystagmus as such. Sensations-wise, there was decreased touch sensation on the right side with no loss of temperature and pain. And other systemic examination-wise, airway was patent. He was breathing at 18 breaths per minute on room air, and auscultation-wise, lungs were clean with bilateral equal air entry. And circulation-wise, his BP at presentation was 140/90, and with a heart rate of 76 per minute, with ECG showing a normal sinus rhythm, and upon auscultation, S1, S2 were present, and no murmurs were heard. Other than that, he was afebrile, had sugars. His sugars at that point of care glucose was 176 milligram per deciliter, with ABG showing a pH of 7.38, PCO2s of 38, bicarb of 23, lactates of 0.7, sodium of 137, potassium of 3.9, and fluorides of 98. Other than that, per-abdominal examination was normal. So now coming to the differential diagnosis, one was stroke, whether it was ischemic versus hemorrhagic, and transient ischemic attack, and intracranial any space-occupying lesion was our primary differential diagnosis at this point of time.
So, how do you have given 3 DDs here? One is the stroke, one is TIA, and one is intracranial as well. So first you have to tell what is difference between the stroke and TIA, and then how will you rule out one by one?
Okay, sir. So TIA per se, it does not persist. One, it will be, there won't be any lesions which will be present on MRI.
Neurological deficits will be
No.
Will be for a transient period of time in a transient ischemic attack, sir.
What is the time duration?
Time duration.
24 hours, sir.
Yeah.
Your patient came within 3 hours.
Yes, sir. Our patient has come within 3 hours, but we can differentiate it by going for an imaging, neuroimaging. And in TIA, there won't be any lesion found on the brain parenchyma.
Okay, that is a later thing. Okay, we consider it whether it is TIA stroke, and how will you differentiate whether it is intracranial as well?
Intracranial as well, then we have to go for an MRI with contrast.
So you mean to say on clinical basis, till now you have presented history and examination. On this much part, you cannot differentiate between these 3.
Usually intracranial space occupying lesions, they are associated with seizures, sir.
No, see, the intracranial as well will have a gradual presentation. Whether patient has headache, nausea, vomiting, any neurological deficit, all that will be gradual. Okay, and your patient has acute onset.
Acute onset.
That can be either stroke or there are other stroke mimics as well. What do you think? What are the other stroke mimics?
Acute hemorrhagic stroke, sir.
Okay, that is part of stroke only. Whether it is ischemic or hemorrhagic, then
Meningitis, seizures.
meningitis also will not have sudden acute presentation like your patient had, na?
Torts paralysis, sir, post-ictal after seizures.
Okay. Other would be hypoglycemia, sir. Symptomatic hypoglycemia, but his sugars at presentation were 176, so that was ruled out.
Also hyponatremia, sir.
So, okay, you read about that, but you tell me now, what do you think what your patient has without going to the radiological examination, imaging?
Okay, our patient, because his presentation, at presentation, his BP was not that high. It was 140/90. And with the lateralized features of neurological deficit, I'd rather go with an ischemic stroke rather than a hemorrhagic one. And yes, sir.
So only based on the lateralization, you are telling it is a ischemic stroke.
On lateralization, and also his BP was normal. So if it were a hemorrhagic stroke, usually at this age, he does not have any history of hypertension per se. He's only known diabetic. So
and also not associated with any seizures or headache or vomitings.
Okay, so what are the risk factors in your patient for ischemic stroke?
you could come again, sir. We didn't get that.
What are the risk factors for ischemic stroke? If you think it is a ischemic stroke, what are the risk factors in your patient?
So based upon him, he has a non-modifiable and a modifiable risk factor. Modifiable being diabetes, and non-modifiable being his age is more than 65. He is a male, and he has a family history of some atherosclerosis.
Okay. Continue.
Okay, sir. So, subsequently, we sent some investigations. Renal function tests were almost normal. Complete blood count was sent, which showed a TLC of 12,000, and platelet counts were normal. Coagulation parameters were also normal. ECG was showing normal sinus rhythm. A 2D echo was done, which was also within normal limits. Subsequently, LFT was normal, and chest X-ray was almost clear. And MRI brain was done, which was showing this picture, where there was left hemipontine hyperintensity in the diffusion weighted imaging with ADC reversal. And along with that, these changes were not visible on FLAIR. So the diagnosis now is acute ischemic stroke, left hemipontine acute infarct with right dense hemiplegia, and also severe dysarthria. He had an NIHSS score of 14. Yes, sir.
Am I audible? Yes. May I know why wasn't a NCCT was not performed and an MRI was performed? Was there any specific?
No, not per se, sir. As we discussed, his because of his presentation wise, it looked more like ischemic stroke, and because our center is MRI and we can get an MRI done within the window within the time period itself, so we opted for it.
Okay.
No.
No, see, when you're suspecting ischemic stroke,
Yes, sir.
so have you heard of the term time is brain? Getting an MRI takes some time.
Yes.
So NCCT you have to do first to rule out hemorrhagic stroke.
Hemorrhagic stroke.
And every diagnosis of ischemic, even if it is not the sign of ischemic strokes are not available, at least you can go for the treatment part. Therapy you can initiate.
Yes, sir.
So NCCT is usually recommended.
Yeah.
And what is the role of MRI here then?
The role of MRI here is to differentiate. One is to establish the diagnosis, and second
Time of onset.
is to
You see, time of onset, you know, it started almost around 9 or 10 a.m. in the morning.
Whether now if we are doing a FLAIR imaging, sir, so whether thrombolysis will benefit him or not, if at all the infarct is visible on FLAIR, then of course he has crossed the window period.
But I don't think that's required for IV thrombolysis. FLAIR is
Yes, sir.
routinely recommended.
Yes,
So, and I think the one advantage of getting MRI done is in NCCT head, maybe when it's a very acute, early subacute infarct, when it's not developed on CT, maybe it's not visible on CT, but on diffusion weighted imaging, you'll probably be able to see that developing infarct. So I think there is only one advantage, but I've given a chance. I think you should always proceed with CT scan first because it's a very quick and rapid and very easy process to go through. And sometimes what can happen is if the patient is little bit agitated or uncooperative, then MRI usually takes 15 minutes to go through. So that can also be a time loss. So if we have an option of CT and MRI, I think CT should be your first modality to go for to rule out hemorrhagic stroke, so that even 10 to 15 minutes can be saved easily when we are going for CT as well as MRI.
Yes, sir.
See, role of MRI is CT has to be done first, so that therapy can be initiated if there is no content, no hemorrhagic stroke. Okay. And then the role of MRI is to establish the diagnosis of stroke as well as to identify the patient who are eligible for endovascular treatment.
Endovascular treatment, yes, sir.
Understood?
Yes, sir.
So you said here that DWI was positive and FAIR was negative.
No.
So for that, what is the role, even in the IVT, what is the role of such imaging? How will it help?
So if it is visible in FLAIR, then he has crossed the threshold. So the infarct is subacute now.
Yeah. So what does it mean? How will it affect your therapy? Decision of your therapy.
Yeah, it means we can't thrombolyze the patients.
No, beta, you can thrombolyze the patient. See, for the thrombolysis, there are two type of windows. One is the 3-hour window and one is the extended window.
Extended
So
one.
in your patient, if your DWI is positive and FAIR is negative, and if it has crossed the 3-hour window, you can still go ahead with the IVT in the extended period of window.
Yes, sir.
This impact is not yet established, as you said, it is not established. There will be some penumbra.
No.
Yes, sir.
So to understand all this, first you have to tell me what is the pathophysiology of stroke. Then only you will understand the therapy and therapeutic part management. So what is the pathophysiology of stroke? Ischemic stroke I'm talking about.
Okay.
Yes.
So there will be either plaque formation, there will be plaque rupture, and that plaque will migrate. And if at all it is originating, if it has a cardiac origin, then either any LA or LV thrombus, any LV aneurysms, any DCMP with severe LV dysfunction, patient presenting with anterior wall MI, and also patients presenting with the heart failure with reduced ejection fraction. Patients to
This is all etiological difference. Whether it can be cardioembolic or it can be thrombosis. Thrombosis can be extracranial, intracranial, or cardioembolic. Like emboli can come from extracranial source like heart. So this all will help you for the secondary prevention,
yes, sir.
not in this management. I'm asking about the pathophysiology. Once the supply is reduced, whether it is thrombus or emboli has gone,
No.
or whether there is a arterial dissection, once the supply has reduced to that critical level of causing ischemia, then what happens? Do you understand the concept of core and penumbra? This is what I am trying to ask.
Yes,
Yes,
sir.
sir.
Tell me that.
Area which is completely infarcted, sir. Penumbra ischemia can be reversible, sir, if we intervene.
So what is the role of your therapy here?
So role of the therapy is to prevent the ischemic events that are going in the penumbra area, sir.
Yes.
Perfusion of
Perfusion
penumbra.
of the penumbra, sir.
Yes, you have to save the penumbra. The all hard work is to prevent the penumbra. That is why Dr. Shubham said that you have to first go with the CT so that you can rule out the hemorrhagic and at least you can start the IVT as soon as possible. Because with each minute you are losing millions of the neurons in that penumbric area where the perfusion is reduced but not yet infarcted the tissue. Okay, so that is the reason he said. But now to identify whether that penumbra is there or not, because in the CT you cannot identify. You are doing the MRI here.
Yes, sir.
Okay, DWI and FLAIR will tell you whether that penumbra is there or not. Other imaging like perfusion imaging also you can do.
Yes, sir.
Understand? But that is only to find out whether that penumbra is there or not.
Okay. Yes, sir.
Okay, so tell me what are the CT findings? If at all, ideally you should do CT first. If you are getting a CT done with a suspected acute neurological deficit patient, what are the CT findings in these patients?
CT findings would be a hypodense vessel sign. In fact, the vessel will be hypodense, or else there will be loss of gray and white matter differentiation, or else there will be
Extensive hypodense spacer.
and also dense MCA sign, and there is-
Effacement of sulci because of
See, why I am asking this is because all these signs will impact your management, therapeutic decisions.
yes, sir. Hyperdense MCA sign.
Okay, so tell me about radiological imaging. Further about MRI perfusion or CT perfusion.
then come again, sir.
Tell me about the radiological perfusion imagings.
Perfusion imagings. Okay.
CT perfusion and MRI perfusion, sir.
Wherein core and penumbra are differentiated
Based on
uptake of
Contrast. Sir.
yeah.
but how? It is This class is just to learn. So you have to speak freely, even if you are wrong.
Okay. The contrast will not be taken up by the core.
See, contrast will reach the infected tissue or the ischemic area through blood.
Yes, sir.
Okay. So there are three parameters. One is the Tmax, okay, or mean transit time. The other is the cerebral blood volume and the cerebral blood flow. Once contrast is there, then only you will know. So in the core area, the infected area, everything will be reduced, the blood volume and the blood flow, and Tmax will be increased. Whereas the penumbric area, the cerebral blood flow will be reduced, volume will be reduced, but it will not be, the Tmax will be not that high, and the volume will be
Low.
but not
Completely reduced, sir.
there are scales on the imaging. Na? You see on the right side of the image, yellow, orange, blue, red.
Yes, sir.
So you can match with those color imaging, color scales. So that is how you differentiate whether penumbra is there or not. If penumbra is there, then you go ahead with the endovascular treatment, because for IVT you did not know unless you are planning for IVT in the extended window.
Yes, sir.
Yes, sir.
Understood? Within the 3-hour window, you did not understand whether penumbra is there or not. If patient has acute neurological deficit and there is no hemorrhage, no contraindication for the IVT, you go ahead with the IVT, irrespective whether it is really ischemic stroke or not.
Yes, sir.
But in the extended window, or if you are planning for the IVT, you need to understand whether penumbra is there or not, because the goal is to salvage the penumbra. If there is no penumbra, there is no point.
Yes, sir.
So that is why you should know about the radiological characteristics also, so that you know whether penumbra is there or not.
Okay,
Yes, sir.
So read about that in detail.
Okay, sir.
Sure, sir.
So here in your patient, this is a posterior circulation stroke,
Yes, sir.
Yes, sir.
and you said initially that there is aphasia and dysarthria later on. So what is the difference between aphasia and dysarthria?
Okay. Aphasia, it is again depends, sir. We classify aphasia based upon fluency, repetition, and comprehension, based upon which it is classified into 8 different types. If all are lost, that is called as global aphasia. But if only repetition is retained, then that becomes transcortical aphasia. But if only fluency is lost, then it becomes transcortical motor aphasia. So like that, there subsequently come Broca's, Wernicke's, anomic, and transcortical sensory aphasia.
In one of your slides, you have written transcortical motor aphasia, and here you have written dysarthria. That is why I am asking, because you are confused here. See, aphasia is the cortical, whether it is motor or sensory, Wernicke's or Broca's.
Okay.
But dysarthria is basically the weakness of the tongue muscle required to produce the speech correctly.
Yes, sir.
Because the motor areas, motor fibers are affected here, whether in the MC territory or whether in the posterior circulation, brainstem.
Yes,
That
sir.
causes weakness of the muscle and the speech become slurred. That is called dysarthria, slurred speech.
Yes, sir.
But in aphasia, patient will not be able to, motor aphasia, patient will not be able to
Motor
He
aphasia.
will comprehend, but he won't be
use
able
the word. He will understand, but he will not produce. So both are different. One is in the anterior circulation, or it can be either in the anterior or posterior. Okay, it is because involvement of the motor fibers, not the speech area.
So dysarthria and transcortical motor aphasia, they both are different entities?
See, motor aphasia is because of the motor area involvement.
Yes, sir.
Dysarthria is because of the motor fiber involvement,
Okay.
the weakness of the muscle.
Yes, sir.
So the speech becomes slurred.
Yes, sir. Okay.
Okay.
Yes, sir.
You will identify motor aphasia will be in the anterior circulation.
Yes.
But dysarthria can be either in the anterior as well as posterior, because it will be affected by the motor fibers.
Okay. Yes, sir.
Why I'm asking whether anterior posterior circulation also, why you should know the difference between anterior posterior circulation stroke?
Because treatment modalities will be changing, sir.
Yes, treatment, these may affect the decision for treatment modalities, therapeutic decisions,
Yes, sir.
like
Mechanical thrombectomy, sir.
what in mechanical thrombectomy?
In anterior circulation with large vessel occlusion, sir.
Hmm.
Mechanical, who are eligible for both Dawn and diffuse criteria, the mechanical thrombectomy is recommended with grade level 1 recommendation, sir.
But in posterior circulation?
Posterior circulation, sir, there were some studies conducted in it. One was the BEST study, which especially in basilar artery thrombus, there was not much difference in patients who underwent mechanical thrombectomy.
But still, so the results are better in the anterior circulation, not in the posterior circulation, but if still it is not contraindicated.
Yeah.
Yes, sir.
Yes, sir.
Okay. So based on the clinical characteristics, age of the patient, previous functional category of the patient, they can decide whether they have to go ahead with the EVT or not.
Yes, sir.
Yes, sir. Yes, sir.
Then move.
Okay. So, yeah, the diagnosis was done, and subsequently the patient was thrombolized at 12 noon with injection altiplase 70 milligrams, with out of which 7 mg was given as a bolus, followed by 63 mg was given over 1 hour. Post thrombolysis, the patient was shifted to the ICU. On day 1,
Okay.
yes,
Wait a minute. So this patient has been thrombolized, right?
yes,
Yes,
sir.
sir.
With altiplase.
Yes,
Can
sir.
you tell me the most common side effects or any danger signs that you are going to see in the patient while he's getting thrombolized for an hour?
One is intracranial hemorrhage, sir.
Yes. So
Angioedema.
what signs, what symptoms patient would be showing?
There will be drop in GCS, sir.
Okay. How many points do you consider that as significant?
More than 2 points, sir. Is
Okay.
considered significant with features of raised intracranial pressure, any anisocoria, any drop in GCS, worsening of neurological deficit. So these
Yes.
are the signs which we look for. And also, if at all the patient presents with hypertension, then we check blood pressure every 15 minutes, along with neurological exam, every 15 minutes for the next 2 hours, every 30 minutes for the next 6 hours, and subsequently 1 hour for the next 24 hours.
Okay. And one is anaphylactic reaction that you have already told.
Angioedema.
And one more thing is bleeding. If there is
Bleeding.
bleeding from any part of the body, so you have to be watchful
Yes.
for. What is the cutoff for blood pressure before initiation of IVT?
Less than 185. Less than 185 by 110, sir. During and after thrombolysis, it should be maintained below 180 by 105, sir.
Correct. You may proceed.
Yes.
1 second, you were talking about some hemorrhagic complication with the IVT. So, is there any specific subset of patient where you think that risk of hemorrhagic complication is more?
Hyperglycemia, sir. In place
Okay.
hyperglycemia and hypoglycemia patients.
Okay, sir. In patients who present with large infarcts, one with anastomosis of more than 25
Good.
and cerebral microbleeds of more than 10 on MRI. These are like high risk patients, sir. High chances of ICH.
Also in cardioembolic stroke, sir.
Age also is there, and another thing is fluctuations in blood pressure, specifically
Yes, sir.
hypertensive response.
Yes, sir.
So these patients you have to be very, very careful.
Yes, sir.
So what are your BP targets in post-IVT patient?
Less than 180 by 105, sir.
Okay.
For the first 24 hours.
Okay. If I keep it 130?
There was a trial, sir, actually on it, the MAPAS trial, wherein they targeted three different, the intervention was done based upon three different blood pressure targets. One was 140 to 160, 161 to 180, and 181 to 200. There was not much difference in all the three groups, but the group with 161 to 180 BP target showed better functional outcomes at 90 days. So less than 180 would be optimal during the first 24 hours.
Okay, less than 180, but what will be your range of blood pressure in your ICU? If you are heading the ICU, you have to take the decision, because less than 180 means 90 or 100 also, 110, 120 also, 160 also.
Okay, sir. Yeah, so
So
initially
what range
160
will
to
tell is your
180.
system to titrate the whatever medication or whatever threshold you are taking to start those medication, or what range you will keep for that blood pressure.
Okay, sir. So my range would be between 160 to 180 systolic. And 90 to 100 diastolic.
Below that,
Below that, matlab the patient has presented with hypertensive emergency, and after which there is subsequent fall in BP. You're asking it like that, sir?
Sir,
no, IVT has been done. Whatever the BP was, IVT has been done. Now the BP is, you are reducing the BP and you have to reduce it to suppose 130 or 120. Like suppose you are reducing it to 160 and she is reducing it to the 120, 130. So what will be the difference?
sir, extreme
What are
intensive
the
level of
benefits or
BP.
what are the disadvantages or disadvantages of different BP thresholds?
Sir, as patient
In
presented with
that one study,
existing
there are 3-4 studies. Enchanted trial, BP target trial. So in the lower BP, the risk of
ischemia will
hemorrhagic
be more.
transformation is less. No, but
Ischemia.
IVT is already done now. The prime concern of reducing the BP less than 180 is to prevent the hemorrhagic transformation.
Transformation.
So if you keep the BP less than 140, the risk of hemorrhagic transformation is less, but the neurological outcome has shown to be
Less.
worse. Even the mortality has been more in patients with lower BP. So target is usually 140 to 180 in most of the ICUs. So what are the drugs? If suppose patient's BP is increasing, what are the drugs which you use to keep this blood pressure low?
Sir, levetolol 10 to 20 mg IV, sir. Over 10 minutes, sir. We can repeat it again. And also IV nicardipine 5 mg per hour, sir. We can titrate up the doses for every 5 to 15 minutes to 2.5 mg per hour. Till the reaching the maximum dose of 15 mg per hour, sir.
Other drugs which are used are hydralazine, enalaprilat, which are mentioned in the guidelines, and clevidipine.
And you can continue your levetolol infusion as well. After the initial bolus doses,
Yes,
you
sir,
can
2 to 8
use it as an
mg per
infusion as
minute.
well. Yes.
Yes.
Yes, sir.
First, you have to tell those drugs which you use in your ICU.
So we usually prefer labetalol, sir.
Do you use nicardipine?
No,
No, sir.
not that often.
Well, you should usually tell those drugs first which you commonly use.
Sir, levetolol. We use levetolol, sir.
Okay. And suppose if this patient had undergone EVT.
Yes.
What do you mean by EVT?
Endovascular thrombectomy, sir.
So suppose this patient had undergone EVT and now shifted to your ICU. So what will be your blood pressure target? What would be your blood pressure management?
Okay, post EVT.
DVD.
No, sir. No idea.
See, what is the risk after EVT? Think about it. There was one occlusion, thrombus. Okay.
Reperfusion
They have
injuries.
reduced it. Yes, sir. Reperfusion injury. So how can you reduce that reperfusion injury?
One is like avoid hypertension.
So one patient shifted to your ICU with after EVT, and 2 hours later, suddenly he becomes unresponsive. And you check the GCS, it is E1 M1.
Okay.
So what is your DD and how will you proceed now? I'm
Mm.
asking this because most of the time for case presentation, it's okay. You should know everything from onset pathophysiology and about IVT and EVT. But most of the time in intensive care, you receive the patient either after revascularization, whether it is IVT or EVT, or without that. So your care starts from the after the patient enters the ICU. So suppose now this patient has come after EVT and 2 hours later, suddenly patient is unresponsive and his GCS is E1 M1 V1.
Yes, sir.
So how will you proceed? What is your DD here?
Okay. We'll start from airway breathing and circulation. If he, as you said, he has a GCS of 3, then definitely he needs to be intubated. We'll take his vitals.
That is standard. That is everywhere standard. I'm talking about, to save the time, we'll discuss what is your DD, what has happened to the patient, what do you think, what has happened, and how will you proceed?
Okay.
Other than I'm talking
Reperfusion
about the
injury.
neurological part.
One is reperfusion injury, and we'll definitely go with the urgent CT brain as of now.
Okay. So what can happen? What will you find in CT? What are the DD?
One is reperfusion injury, one is transformation, hemorrhagic transformation.
That is what reperfusion injury, na? Hemorrhagic transformation हो जाता है उसमें. Blood flow will increase suddenly in the disrupted blood-brain barrier area, infarcted area, core area, and hemorrhagic transformation will be there.
Okay.
Other than that, suppose CT done, there is no hemorrhagic transformation.
Then it could be CT done, no hemorrhagic transformation. It could be reversible cerebral vasospasm, sir.
Vasospasm.
No. Okay.
So it can be a seizure. It can be another reocclusion. EVT was done. Now again there is
Reocclusion.
another reocclusion of the vessel.
Yes.
It can be hypoglycemia. So before CT, can you differentiate between hyperperfusion injury or reocclusion of the vessel? Suppose CT is taking time. There is problem with shifting the patient, or even if you have a portable CT, it is taking time to come to your ICU. So clinically, can you differentiate?
Hyperperfusion. No, sir.
No, sir.
See, in hemorrhagic transformation, if patient has deteriorated to this level, definitely the hemorrhage will be large, involving a major area of the infarcted core area. So mass effect will be there. So pupillary examination will play a role here.
Only Sukoria. Okay.
Okay. But if there is reocclusion, definitely there will be no
There
pupillary.
won't be much features of raised ICT, you are saying, so okay.
Then mostly patient will have thrown a seizure because of sudden reocclusion, there will be hypoxic damage to that area and patient will throw a seizure, whether convulsive or non-convulsive. That is why he has become M1. So clinically also, prior to CT, you can find out clinically, you can predict whether it is a reocclusion stroke or it is a hemorrhagic transformation, hemorrhage.
Yes, sir.
Yes, sir.
I sit in the patient. Okay. So clinical, you have to understand the role of neurological examination in stroke patients.
Yes.
Yes, sir.
Okay, tell me. Okay, go ahead.
Okay. Subsequently, the patient was shifted to the ICU. On day 1, he had a GCS of E4, V4, M6. He was conscious, coherent, and following commands. He was able to protect airway, and he had some deviation of mouth to the left, and power on the right side was still 0/5. But he was hemodynamically stable, and echo was done, which was within normal limits. And subsequently, on day 2, there was not much change in sensorium.
Okay, this is a clinical course. Leave the clinical course. The patient has come on the day 1 only.
Yes, sir.
You have done the routine blood investigation, which you had earlier told,
Yes.
and one MRI also you had done. What other investigations are important in such patients?
In such patients, we'll start with point of care glucose, sir. Glucose at
So
presentation.
that is you have already told.
Okay.
Rule of hypoglycemia and all.
Okay. Other than that, coagulation
You
parameters.
have told me the investigation required for the which will define the course of therapy in the acute setup.
Okay, so one will be.
What other investigation will help you to decide the future course or future therapy of these patients?
Yes, sir. Definitely. We'll start with complete blood count, sir, on which we'll look for platelet counts. If it is less than 1 lakh, then that's a contraindication for thrombolysis. And other than that, coagulation parameters, PT of more than 15, APTT of more than 40, and INR of more than 1.7. All of these, again, the patient cannot be thrombolized, investigations wise.
No, see, you have already told we'll not waste the time on all these things. You already told the blood investigation, and we assume you know all these things. That's why you told. What I'm trying to ask is for the future acute management part was discussed. Now for the secondary prevention.
Okay.
To find out the cause of the stroke.
Yeah.
Then only you can do the secondary prevention. You can prevent the re-stroke.
Yeah.
Yes, sir.
So what all investigation you will do in these patients?
We take ECG, sir, to look for any AF, 2D echo to look for any early apical clot.
LA and LV clot.
Clot.
Subsequently, carotid Doppler can be done. A CT cerebral angio can be done to look for blood flow. And a TSH also, TSH, homocysteine.
Fasting lipid profile.
Lipid profile.
See, when you said you did the MRI or suppose CT you are doing, so it is always better to do the angiogram of cranial and extracranial vessels instead of doing carotid Doppler later on.
Yes, sir.
Yes, sir.
Okay. Echocardiography, definitely you need to rule out cardiac clots or vegetations or severe LV dysfunction.
Yes, sir.
Similarly, you need cardiac enzymes as well in those patients who you think may have positive ECG changes, hemodynamic instability to rule out acute MI. Acute MI will also have clot in the heart.
Yeah.
Yes, sir.
Yes, sir.
Okay, go ahead.
Okay. Other than that, his dysarthria was slightly better. There was no pulling of secretions as such. He was protecting his airway. He was hemodynamically stable, and we did a fasting lipid profile, which was almost normal. And
these are the clinical findings. You tell me how will you ICU patient has come next day, second day, you have done all the investigations, but your ICU care, the supportive care, what all that will include in these stroke patients?
Sir, we have to take measures to prevent ICP, sir, rise in ICP, sir. So to maintain the cerebral perfusion pressure of more than 60 mmHg, sir. Head end elevation, sir. Head end elevation to 30 to 40 degrees, sir. Will prevent tight ET ties, which prevent the drainage of cerebral veins, sir. Will maintain normoglycemia, normothermia, and also BP also should be maintained below 180 by 105, sir. And also continuous GCS monitoring. And if needed an osmotherapy, if we suspect any high increased intracranial pressure, osmotherapy will start, sir.
When will you start osmotherapy?
Okay, sir. If we suspect, if the suspicion that the patient has high intracranial pressure, then we can go ahead with high osmolar solution, sir.
So if it's a small infarct and there is no midline shift, there is no edema, will you still go for this therapy, osmotherapy?
Small infarct, midline shift, sir.
There is no midline shift.
No midline shift.
There
Okay.
is no.
Usually no, sir. Usually we go for it in posterior circulation strokes because the chances of herniation are quite high there.
So there is if there is a brainstem compression, if there is a hydrocephalus,
Yes, sir.
or you feel that edema is cropping up, and so you may start osmotherapy.
Yes, sir.
Yes, sir.
Okay.
Okay, 3 days later, day 3 of your ICU care, again the patient has become drowsy.
Day 3. Okay, sir.
We'll get one more non-contrast CT, sir, to look
What
for
is the DD?
sir,
DD.
hemorrhagic transformation, sir, after thrombolysis.
One
Okay.
is definitely yes, but one is second is one more ischemia, one more insult to the brain in the form of ischemia.
Any seizures, sir?
Seizures, hypoglycemia, again the same thing. Or NCSC is one more. And also
There are limited things in the brain. ठीक है, either यहाँ पे hemorrhage हुआ, as you said.
जी sir.
अभी तक you were talking about raised ICP और कैसे बढ़ेगा? Cytotoxic edema.
Yes sir.
Yes, sir.
Then you will start your osmotherapy.
Yes,
Other
sir.
than that, what else cause can be there? अभी Dr. Shubham ने बोला.
जी sir.
There can be hydrocephalus.
Yeah, obstructive hydrocephalus. Yes.
We are
There
talking
can
about
be.
this case.
So.
Sir?
Yes, we are talking about this case, particularly posterior circulation infarct.
Yes,
So
sir.
hydrocephalus can be a finding.
Yes,
Yes,
sir.
sir.
So how will you monitor your patient?
Post thrombolysis, sir.
A stroke patient has come. Other than that, clinically, neuromonitoring I am asking about. Neuromonitoring, anything you particularly want to use or you use in your ICU?
We usually go with the clinical monitoring, sir. Clinical monitoring and clinical exam. Yeah. Other than that,
Sir?
Role of neuromonitoring other than the clinical examination.
Neuromonitoring, as shown by the best trip trial, there was not much benefit of invasive ICP monitoring as compared to the clinical examination thing.
Can there be a role of non-invasive monitoring like cerebral oximetry or TCD?
Yes, sir. TCD definitely.
How?
By measuring the velocity of middle cerebral artery, sir.
See, beta, you have to monitoring का सब उसमें एक ही limited तरीके का role रहता है in the brain. So here TCD you can use for several things. One is to know the perfusion.
Perfusion.
Okay, after your revascularization, if you have done previously done better, otherwise still you can know whether there is reocclusion, whether there is perfusion is increasing, the patient is at the risk of hyperperfusion, then you can further control the blood pressure.
Yes, sir.
Yes,
So
sir.
TCD can help you in defining the threshold of the blood pressure management.
Yes, sir.
Okay, if there is increase in the cytotoxic edema, TCD can help you by telling you whether there is raised ICP. The feature of raised ICP waveform will be there. The flow velocities will reduce in that particular territory. So TCD can help you in that way as well.
Yes,
Then there are other monitorings. You can use NIRS, as Dr. Shubham said.
Yes, sir.
sir. ONSD.
Towards this ONSD you can use.
Yes, sir.
Yes, sir.
Even if you are not doing, you have to read about that and think how you can use, because slowly ONSD anyway everywhere they have sonocyte or ultrasound machines.
Yes, sir.
Yes, sir.
So ONSD also can be helpful. So definitely there is role of neuro monitoring. You can identify the patients early, whether they are at risk of reocclusion, whether they are at risk of hyperperfusion, whether they are at risk of raised ICP. You can identify those patients and you can take the therapeutic measures at early stage, and you can definitely improve the neurological outcome.
Yes.
I think NIRS can also be quite useful here if you are applying it since your day one of arrival of your patient in the ICU. So you'll get a rough idea of the oxygenation in both the hemispheres. And if there is a gross dip in the oxygenation on the infarcted side, then probably it can give you a idea that probably the patient may land in a soup or patient may be deteriorated. So you may get a little bit more cautious. So I think it's a non-invasive technique, and it's a very useful technique in these type of patients.
Yes, sir.
Can be useful.
Okay, I was talking about supportive care. So please tell me what all medications you will write for this patient. Your drug chart.
Dual antiplatelets, sir.
Dual antiplatelets.
First
What
one,
are the recommendations? Whether you start dual antiplatelet in all stroke patients.
no, sir. We go for dual antiplatelets in patients who are not being thrombolized or presenting out of window period. For them, we can go with dual antiplatelet combination of aspirin and clopidogrel for the first 21 days since onset of symptom, and that is used as to prevent secondary stroke. That was the chance trial, but usually dual antiplatelets, no sir, we go with a single antiplatelet, aspirin, 325 mg, 160 to 2 to 325 mg of dose per day.
When do you start dual antiplatelets? Even if IVT was done, and if you are starting the single antiplatelet, then after how much time you start after IVT or EVT? What is the
Usually we wait for 24 to 48 hours, sir, as per the guidelines, before starting antiplatelet therapy.
and can you start dual antiplatelet after IVT?
Sir, after 48 hours, we can, sir.
For which patient?
If there are chances of recurrent stroke patients, sir, with risk factors.
See, obviously there are some risk factors. That is why this patient landed up in acute ischemic stroke, no? Okay, so see, the recommendation says that you can start the antiplatelet therapy after 24 hours of revascularization procedures. Okay, and that is for the secondary prevention. But those patients who are already on dual antiplatelet, you should start dual antiplatelet.
Okay, yes, sir.
Unless there is any contraindication. Usually in the early stage, people do not start the dual antiplatelet if patient has a large stroke, large infarct,
Yes.
because patient may go for the decompressive craniectomy or AVD placement or shunt procedure.
No.
So usually they start the single antiplatelet therapy. They go for dual antiplatelet as soon as possible in those patients who are already on dual antiplatelet therapy and who had landed in seizure despite the dual antiplatelet therapy.
Yes, sir.
So what other medications you will write? You will be giving to the patient?
Statin, sir.
Okay.
On ulcer prophylaxis.
Okay.
And if at all he's not able to take orally, then we'll start him on nutrition.
See, sorry, I would like to interrupt. Sorry, this
Yes.
is a posterior circulation infarct. Now, so the things you have told it become more important in posterior circulation infarct because brainstem infarct can
Yes,
lead to bulbar weakness.
Yes,
It
sir.
can lead to problems in deglutition because of lower cranial nerves involvement. So you need to do a deglutition assessment before giving feed, or if you
Yes,
feel that nerves are involved, then we may give feed by rice tube.
Yes, sir.
Continue.
What is the role of anti-epileptics?
Anti-epileptics per se have
It's not recommended, sir. Prophylactic anti-epileptic therapy is not recommended, sir. Unless there is ongoing seizures, if there is any ongoing seizures only, we give, sir. Otherwise, there is no, it's not recommended, sir. Prophylactic anti-epileptic agents are not recommended, sir.
and even if the patient presents with stroke, they say till 7 days anti-epileptic treatment can be given, but after that there is no role of it.
Then other supportive care. Regarding feeding, as Dr. Shubham was discussing, what are your concerns, especially in your patient? He said bulbar weakness will be there.
Yes, sir. So one is any pooling of, look for any pooling of secretions, any gurgling sounds, any signs of aspiration, any oxygen requirement, any hypoxia, decreasing saturations on monitor. So these will be my concerns, sir, especially with this case.
See, these patients, even when they have bulbar weakness, if there is no pooling of secretions, the clinical features of respiratory distress or desaturation, they all come later on.
Yes, sir.
They come only once aspiration pneumonia has set in.
Yes.
So you have to start the nutrition early.
Yes, sir.
What you do is you always start the
And
not enteral nutrition through NG or NG. And before you start the oral feed, you go for dysphagia screening in these patients.
Yes, sir.
yes,
Okay, that is a very important thing, dysphagia screening in all the stroke patients.
Yes, sir.
Even in the anterior circulation also, you have to screen all the patients for the dysphagia before starting the oral feeding.
Yes, sir.
sir.
Other things you will taking care of in these patients, stroke patients.
One more thing is DVT prophylaxis, sir.
Hmm.
We usually go with intermittent pneumatic compression devices from day one.
Hmm.
Anything else?
Okay.
If this patient has a, if the patient has atrial fibrillation on ECG and has a clot in left atrium, would you like to add something to the prescription, or you will continue with dual antiplatelets or single antiplatelets?
Clot in the left atrium, you said, sir. AF with a left atrial clot.
Yes.
Okay.
Anticoagulation.
Would you continue?
Anticoagulation.
What will you prescribe for that?
Usually for LA clots, we go for vitamin K antagonist, sir. Like warfarin.
Suppose you suspect it's an embolic stroke. You witness atrial fibrillation in the ECG,
Yes,
and
sir.
probably clot is found or not. But so, what are you going to give something for that prophylaxis, for that embolic prophylaxis, or you are going to continue this antiplatelets only?
Heparin, we can start.
Yes.
Okay.
Low molecular weight vancomycin can be started in these patients instead of antiplatelets if you feel that it's a embolic stroke.
Okay, sir. We'll move ahead with the case, sir.
Huh.
Yes.
Okay, then subsequently a CT brain was done after 24 hours, which did not show any signs of hemorrhagic transformation. And simultaneously, a CT cerebral angio was also done, which was showing right vertebral artery hypoplasia. With basilar artery, there was a thrombus in it for a length of 6 millimeters. Okay. So these are the scans. And subsequently on day 3, there was mild improvement in power on the right side. It was 1/5, and his speech was slightly better. And subsequently, he was mobilized out of bed. And on day 4, he was well oriented. He was following commands. There was not much difference in his power. And subsequently, on day 5, he was discharged on dual antiplatelets and statin in a hemodynamically stable state with a GCS of E4, V5, M6.
Okay, so you have a patient of stroke and suddenly there is deterioration. You see that patient had undergone IVT and it's day 3. You do a CT and there is malignant infarct with edema. And you give a call to surgeon and they want to go ahead with the decompressive craniectomy.
Yes, sir.
So before the decompressive craniectomy, what all preoperative care you will be taking care of? Decisions.
Okay, basically he has raised ICP, which is causing his neurological worsening. So first of all, we'll start with some a bolus of hyperosmolar therapy, either mannitol or 3%. Mannitol at a dose of 1 gram per kg, not exceeding 200 grams per day. And also we can go with hypertonic saline 3%, 5%, and 23.4%. 3% can be given at a dose of 2.5 to 5 ml per kg over 5 to 20 minutes. Same with 5%, whereas 23.4% saline is given at a dose of 30 ml stat over 10 to 20 minutes. So that will be the first thing. Second thing is because he has increased raised ICP, he'll have like a low GCS, he'll be intubated. So we'll target his PCO2s between 30 to 34 millimeters of mercury. There is that. Other than that, sedation and paralysis to minimize his efforts, anything that could translate to raised ICP, further worsening of that raised ICP. And 1, 2, 3. Yeah, if at all, despite all this, this comes in the tier 1 of management, then subsequently, if no worsening and if no improvement, then subsequently can taken for surgical decompressions.
The family wants to know the benefit of decompressive craniectomy.
Okay, so in cases, in a lot of there were multiple trials conducted on decompressive craniectomy from decimal destiny 1 to if we come to a conclusion of it, the age, if the patient's age is more than 60, their functional outcome, their independence at 12 months was near 0. But in patients who are less than 60 years of age, almost 18% of them attained independence at 12 months. But there was decreased mortality associated in both groups, but the chances of vegetative states were quite higher in the older populations. But yeah.
So basically what happens is decompressive craniectomy in acute ischemic stroke patient, it helps in the reduction of mortality.
Yes, sir.
It does not have any significant role in the functional outcome.
Functional outcomes, yes, sir.
So how do you measure the functional outcome in such patient?
We usually go with the modified Rankin score. Previously, they also used Berthel index.
What is this modified ranking scale?
Modified.
0 is normal, sir. With mild disability, we give us 1. Moderate disability 2. Severe disability as 3.
It's okay, read about it.
Yes, sir.
See, your preparation, I do not think it is up to mark. The thing is, you have to read not just the guidelines and their main points, you have to read the articles from where the guidelines recommendations are taken. Okay, then only you will understand. You have to understand in the stroke first, you have to understand the clinical features of the stroke. What are the stroke mimics? Okay. what are the stroke mimics, how to differentiate between them, what are the etiological causes of the stroke, like cardiac embolic or thrombosis, because that will help you in deciding the secondary prevention. If it is cardioembolic, you will give anticoagulant. If it is thrombotic, or you will go for antiplatelet therapy, as well as you can think of stenting if there is carotid stenosis. If there is intracranial stenosis, you can think about intracranial stenting.
Yes,
So the etiology will help you in deciding the secondary prevention. Then you should know about the core and penumbra concept, because here you are trying to salvage the penumbra. You cannot do much about the core.
Yes, sir.
So in the acute part, you should know how to know if there is any penumbra. So once you suspect a patient who has come to you with ischemic stroke, you do a sugar, you take brief history, brief clinical examination quickly, you get a CT done. If there is no hemorrhage and still there are signs of neurological deficit, whether it is confirmed or not, it is ischemic stroke, you go ahead with the IVT. Then to know about the penumbra, you can go ahead with CT perfusion or MRI with diffusion and flare. You can see if penumbra is there or not. If penumbra is there, that will help you in deciding those patients who can go for IVT in either extended window or who can go for EVT. EVT also, there are different windows. You can these days people are getting undergoing EVT even within 24 hours.
In 24 hours, yes, sir.
18 hours, 20 hours. So what are the criteria? Previously, the criteria for undergoing EVT, whether it was within 6 hours or it was within 16 hours, it was all clinical. Age of the patient, NIHS score, clinical parameter, clinical condition like diabetes, previous stroke history and all. But these days, even patients who are not having these things, the perfusion thing, even if there is penumbra, they go ahead even at a 24-hour gap for EVT.
Yes, sir.
Those patients who has the wake up stroke, because you do not know the time of stroke. So penumbra, knowing the penumbra is very important, whether penumbra is there or not.
Yes, sir.
Okay. Once whether patient goes under any revascularization procedure or not, patient comes to you, you have to monitor the patient for immediate complication and delayed complications. Immediate complication can be related to therapy, whatever he had undergone, or like suppose he had undergone IVT, patient is at risk of angioedema, hemorrhage. Patient has undergone EVT, patient is under risk of reperfusion injury or reocclusion. Patient is at risk of seizures.
Yes,
sir.
Patient is at risk of drop in G-cell and losing the airway.
Yes, sir.
Okay.
Sir.
After 2 to 3 days, patient will have secondary delayed complications like edema, increased ICP. Again, patient may have seizure, hydrocephalus. So you have to keep monitoring the patient. You have to simultaneously use the available neuro monitoring. आजकल के जमाने में तो हर किसी के पास almost कुछ ना कुछ है.
Yes.
So with neuro monitoring, you can monitor the patient for the monitoring of revascularization success, reocclusion,
Yes, sir.
edema, raised ICP. Okay, whatever you have, you can use that monitor, whether it is NIRS, whether it is TCD, whether it is ONSD, whatever you have to use that. Okay, start using all these things. Then only you will know what patient is at risk.
Yes, sir.
In the secondary prevention, if patient had AF, there is cardioembolic, you have to go for anticoagulation. If patient had thrombotic, you have to go for antiplatelet. You have to even see the patient's comorbid conditions.
Yes, sir.
Okay, if patient is in your ICU and patient suppose had undergone EVT, or immediately patient deteriorates, has hemorrhage and has to undergo decompressive, you should know how to reverse the RTPA. Or if patient is already started on Clexane or antiplatelet, then also you have to, like suppose if patient is planned for decompressive, you should know कि
Yes.
patient को what are the risk IVT था तो कैसे reverse करना है, blood products has to be arranged,
Yeah.
Yes, sir.
because all this delay will increase the damage to neurons.
Yes,
Even
sir.
if stroke has occurred, you can still prevent the secondary damage.
Yes, sir.
Yes, sir.
You have not told about IVT mein what are the other options. Altiplase is the drug of choice, but do you think there is any other option?
Yes, sir. But there is. Yeah.
Tenecteplase, sir.
What is the difference between altiplase and tenecteplase?
Tenecteplase is more fibrin specific and it's less inhibited by plasminogen activator inhibitor, sir. And also has a longer half-life, so it can be given in a single IV bolus, sir. It is not superior, it's neither superior nor inferior, sir, but it can be used as an alternative to altiplase, sir.
Especially in what population? See, recent studies, they have shown that it is, you are right, it is not superior or inferior, but they have shown that its result are still better in patients with LVO, not compared to altiplase, but compared to any other population. I'm not comparing tenecteplase and altiplase. Tenecteplase results are better in patients with large vessel occlusion compared with, what do you mean by large vessel occlusion?
I think they have disconnected from their sides or some issue, I think, technical issue.
Yes, yes.
Yeah. So there's been a great masterclass discussion, sir, and I hope both Dr. Aqeel and Dr. Vathsalya have got a good idea about how to prepare themselves for the case presentation and preparation. And really, the breadth of the discussion was wonderful, from the basics to the intricate things. So I really thank Dr. Amit Goyal and Dr. Shubham Khandelwal for taking this great presentation. Yeah, Dr. Pathan. They have connected, sir. Yeah, they have connected.
Yes, sir. There was a disconnection actually.
Yeah, I understand. So, sir, any final words, sir?
Just another thing for the supportive care, always take care of the dysphagia screening in these patients, GVT prophylaxis, and
Yes, sir.
one of the most important and ignored aspect is depression in these patients.
Yes.
That also has to be taken care of.
Yes, sir.
Okay, so that's a wonderful discussion, a real masterclass. I hope Dr. Pathan and Dr. Vathsalya have got a good idea about how to proceed with a case presentation with a cerebrovascular accident case. So you take these questions seriously and learn more about them, research about them. So be prepared yourself. I really thank Dr. Amit Goyal and Dr. Shubham Khandelwal for the great contribution and a wonderful discussion. The breadth of the discussion was really wonderful, from the basics to the intricate things. Really, thank you, everybody. Thank you.
Thank you, sir.
Thank you, sir.
Thank you. Thank you, everyone. Have a good night.